Then we start. Hello, everyone. Today we gather together to kick off the 8th International Conference, aiming to promote academic exchange and cooperation among countries dedicated to stroke pre-hospital care. On behalf of the organizers, I would like to extend a warm welcome and a heartfelt gratitude to all of you for your attendance. We look forward to your in-depth discussions and wisdom sharing. The agenda is tight, but the content is rich. I wish the conference a complete success. Thanking everyone again.
Now we invite Professor Anthony Tony from King's College to give a brief speech. He's the founding president of the Coalition of the Special Task Force for Stroke.
Thank you, Renyu and Jing. Well, welcome to the 8th International Symposium on Pre-Hospital Care for Stroke, organized by the World Stroke Organization Task Force on Pre-Hospital Care and the Coalition of Special Task Forces for Stroke. I'm especially grateful to Renyu and to Jing, who have put all the work in to getting this meeting organized and ready for presentation today. I'm sure it's going to be a great session. Pre-hospital care has been the rather neglected part of the stroke pathway, and that has major consequences because the failure to improve pre-hospital care, especially in low and middle income countries, but also in high income countries, is one of the major reasons why we're not delivering acute treatments that are currently available to the vast majority of patients around the world who have stroke. So CSTS and the World Stroke Organization Task Force have helped, I think, to highlight the problems. And in some parts of the world, particularly recognizing the work that Jing has done in China, the task forces have done some fantastic work in raising awareness amongst the public and professionals and organizing pre-hospital systems of care, which have made a fantastic difference. The lessons that have been learnt from those experiences, I'm sure, are applicable worldwide. It's been an honor to be the founding president of CSTS. I think that we have made progress over the last 5 years or so, but I'm now delighted to be able to hand over to Professor Gary Ford, who's been an international pioneer on developing improved systems for pre-hospital care, and I'm sure many of you will be well aware of the work that he's been doing. So I think CSTS is in very good hands under his presidency now, and I look forward to seeing further progress. So thank you all very much, and I would now like to hand over to Gary to say a few words.
Thank you, Tony. I'd like to say welcome to all the delegates. Just to add to Tony's comments, we all recognise pre-hospital care as a critical part of the pathway, and I think importantly we're at a significant point where we're seeing advances in both the interventions we can deliver in the pre-hospital setting and the organisation of care with regard to service models. And in that regard, I think we're lucky to have some really excellent speakers, and I'd like to thank them for giving up their time today. We really appreciate that. The other thing we appreciate is the support of the World Stroke Organization for this work and this conference and the Pre-Hospital Task Force. And I think that's reflected in that we've got amongst our speakers the current president, future president, and 2 ex-presidents, so all the president's men. But really appreciate that. I'd like to say a special thanks to Jing Zhao and her Chinese colleagues for organising this and getting the engagement of the Chinese community in Nantong and Shanghai. And particular thanks to Renyu, who has never-ending energy and has put tireless efforts into organising this. And we wouldn't have got to where we got to with this meeting or with the CSTS in general. A final thank you to Tony, who has done an excellent job in being the founding president of this organisation and the task force, and I hope to be able to at least try and match his efforts in him handing over the reins.
Dr. G. All right, let's move to the next. We welcome the WSO president. He will give both opening remarks and talk about stroke pre-hospital care as a focus of the next 2 years for the WSO. Dr. Gerard Pendium.
Yeah, thank you, Renu and Zing, and then the entire task force members of WSO pre-hospital care and for organizing this. I will just make a brief comment about what is the current pre-hospital care globally and what are WSO's perspectives for the next 2 years and how we can work together. So what I'm going to do is just a brief mention about all the important WSO activities and look at the gaps in the pre-hospital care and what are the emerging models and how as WSO we could move forward the next few years. So we know that our mission is to reduce the global burden of stroke through prevention, treatment, and continuity of care. And most of us know how WSO was formed in 2006. We have our past presidents here, and they were greatly instrumental in bringing two big organizations together to merge to form a single organization. And we have more than 3,500 individual members, about 100 society members, and 40 board members, and 11 executive committee members. Our vision is a world free from stroke, and the values are like equity, integrity, excellence, transparency, partnership, and innovation. We collaborate with many organizations, and these are some of the important WSO's initiatives, and advocacy is an important one, and then implementation of quality stroke care, and which includes pre-hospital care, WSO's Angels Initiative, Global Stroke Alliance, started by Dr. Martens, and the involvement of SSOs as well. So for pre-hospital care, if you look at in the WSO roadmap, we have this minimal stroke services, essential stroke center, and advanced stroke center, and pre-hospital care is vital in all these healthcare levels. And the World Stroke Organization Lancet Neurology Commission, we published in last year. There are four pillars for the pragmatic recommendations: the acute stroke, rehab, prevention, and surveillance. So in the pre-hospital care comes under acute stroke care. But I would say that this particular task force is well positioned to come up with pragmatic recommendation based on today's discussion and many other future activities that we'll be holding regarding pre-hospital care in different regions of the world. The barriers at patient level, and if you look at rapid access to care, number one is awareness. Lack of awareness of stroke symptoms. There are social cultural beliefs, like in many places the first response is to go to a unqualified medical practitioner, and particularly rural areas of many countries. Barriers at health system level, again, we struggle with culturally appropriate educational materials for recognizing stroke symptoms and creating public awareness, and lack of state-funded medical transportation. So emergency care services are ill-equipped to deal with acute stroke. So these are the several challenges that we have when we try to implement acute care, including pre-hospital care. I'll just quickly give some important findings of this particular project. The 1 year finding, this is a very innovative implementation research looking at high-quality patient-centric integrated model of emergency care systems in selected districts of India, supported by Indian Council of Medical Research. There are 5 districts in the country, and we had our annual meeting just a few days ago, and I'll just share some, maybe an important finding of a survey which was done at the population level in all the 5 districts. I have findings from 2 districts. So basically, it involves a formative research, qualitative interviews with multiple stakeholders, and then quantitative data, work with the stakeholders, co-design workshop. So we have completed the first co-design workshop particularly looking at the ambulance services and existing infrastructure at different levels of healthcare, primary healthcare center, community healthcare center, district hospital, and referral hospitals. And this is a survey that we had completed in our district, where about a total of about 6,000 population in rural and urban we had covered, and about 150 households, about 147 individuals. If you look at the emergency care for the last 1 year using a questionnaire, we are able to identify the number one is trauma and burns, about 14. If you look at STEMI is 4 and stroke is 2. So most of the other emergencies were very less, and so these were the patients who had used the ambulances for these emergencies. So the use of ambulances more for trauma and burns. And so this is another center in southern India where they looked at from the population-based data, based on the individual conditions, how they were able to access treatment in a time-sensitive manner. So if you look at here, trauma, less than 1 hour in definitive care out of 170 patients that they surveyed in this southern state, 74% of them were able to access within 1 hour. This is a small union territory called Puducherry, and it's a small place compared to our district here. The burns about 71%. Stroke, you can say less than 4.5 hours. 5 out of 11 patients were able to access this. So this is the ground level reality that we're able to assess from this particular study. So a lot of work needs to
Can I
be done.
interrupt a second? Yeah.
Okay, I think this study is important, so probably.
Yeah, now we can see your screen.
Yeah, I'm extremely sorry. Yeah. Okay, I think the previous slides were a lot about WHO, so it is okay. And so this particular implementation research, I'll just quickly go through in 5 districts of India, and we have a 1-year review of this particular project, and some of the important findings I will just share. So this basically involves a formative research, which is qualitative interview of all the stakeholders, including the patients, public, and all the hospital staff, government officials, and then quantitative data from the community, population-based survey, and a co-design workshop. So we have reached a model 0. That is where we are now. It's a 3 years project. And based on the survey that we had done in our district, if you look at the type of emergencies, trauma and burns is the highest, followed by STEMI, stroke, and acute respiratory illness, and the maternal and neonatal emergency. So this is a small population, and this is similar in all the other 5 districts of the country. And there's a place called Puducherry in southern India where they looked at the data that they collected from the population and compared it with how they were able to access the healthcare facility in a time-sensitive manner. So here you can see for trauma, less than 1 hour access to treatment is about 74%. Burns, again, 71%. For stroke, less than 4.5 hours, about 45%. STEMI, less than 6 hours, 82%. For maternal and neonatal maternal emergency about 100%. Snake bite is 100%. Poisoning is about 50%. So there are a lot of ground level challenges, and the awareness about stroke it plays an important part, including STEMI here, and so a lot of work we need to do. So this is again further looking at the critical time period for trauma less than 3 hours. So you can see the percentage, even though it's a small number, and it gives very important information about what is happening at the population level, the health-seeking behavior during emergency. So WHO action plan for pre-hospital stroke, I think we need to come up with a context-specific models. Every country is different, and within a country, there are several provinces and states where the healthcare infrastructure could be different. We need to look at context-specific models involving private players also. In India, we recently, through the Angels program, I think there has been a MOU signed with a private ambulance agency, which is operational in about 25 small cities of the country. And I think on Monday, the Angels initiative, they are going to sign a MOU with one of the important private ambulance services, the GVK Group, which operates the 108 ambulance across the country in a private-public partnership. So we need to look at country-specific model. Global stakeholders meeting is very, very crucial. If you look at all the ministerial meetings that has been held in the past, in the last 2 years, in the Global Stroke Alliance, we have not had any separate session with pre-hospital care. So there is going to be a Global Stroke Alliance meeting in Hanoi, maybe June or July. I need to fix a date. Probably for this particular meeting, we could involve countries from Asia, policymakers from Asia, Oceania, and Western Pacific regions. And this will be a great opportunity. We could have a half-a-day workshop or a one-day workshop. We'll be inviting the ministers and the policymakers from many of these countries. So this will be a great opportunity where we could organize a workshop or a consortium where we could discuss and come up with country-specific models. And this would be a great way to move forward in the area for pre-hospital care. And today's meeting, whatever consensus or recommendation that you have, we could work out strategies, particularly having a demonstration project in countries where we don't have pre-hospital care or a minimal care. Can we implement and roll out a demonstration project with some funding by which we'll be able to see how in a place where there is non-existent pre-hospital care, we're able to do it. So these are my strategic plans for the coming years. I think the meeting in Hanoi would be a very good opportunity for all of us to come together and discuss with the policymakers and move forward. So thank you. Yeah.
Thank you very much. We see Dr. Shenminji is here. Welcome,
Yes.
Dr. Shenminji, to give me a welcome remarks. He's the president of the Stroke Prevention Project National Health Commission. He's the president of the China CSSA.
Yeah. Dear Professor Tony, Gary, and Pandian, and Anderson, and Professor Ren Yuniu, and thank you for your help to Chinese stroke prevention and treatment to improve Chinese stroke treatment quality.
Opening remarks and a welcome speech. And so next, I'm going to do a brief overview of what we did in the past 1 year for the task force for the World Stroke Organization, joined with CSTS. So first of all, today is a great moment that I have a transition for the presidency for the CSTS. We appreciated Professor Anthony Rudd for his great presidential service for the CSTS. We'll honor that when we get together. We'll honor his outstanding contribution to the work to improve the stroke pre-hospital care. So I'm going to give a very quick, brief overview of some of the work we did for the World Stroke Organization Task Force for Hospital Care and the CSTS. So as you know, we do the annual meeting every year. Last year, actually, we did the on-site meeting right before the World Stroke Organization in Toronto. This is the scene. At that time, we had a panel discussion. We invited stroke survivor to participate in our meeting, and we also produced a film, which is an award-winning film, a series form we plan to do, My Stroke Story. This is the episode 1. As you can see, we put this on tube, but we already have 341K views, and it was selected by the 2024 WHO Health for All Film Festival. We did a lot of studies in different countries and regions. This is a study in Nigeria looking at the stroke awareness and use of national emergency numbers. I'm not going to go through the details about it. This is one of the study which June will present later on with his colleague about the study we're doing in Mexico. Basically, we investigate investigate to see which kind of stroke awareness program will be most effective. And then we found that the program we're doing for stroke called 911 in Spanish has very effective there. This is another study we did in Nigeria. Basically, we try to do different studies in different country regions. As Dr. Pandian mentioned, this is a good way to engage global experts to work in this area to improve stroke pre-hospital care globally, especially in low and mid-income countries. We recently hosted the ACE meeting in Shanghai and Nantong, and also today we have this online meeting. So in Nantong, we premiered that our My Stroke Story first episode in Nantong in Chinese. It was very successful and attract the media report, which will increase the impact of our effort. I want to shout out for Dr. Zhao, with the support of Dr. Xu Mingji's China Stroke Specialist Alliance. Under that organization, she started the Stroke Health Education and Promotion Expert Committee. Basically, that's the team member. This is a team member from all across China. Over 200 people joined this effort to promote stroke. Mostly, major focus is on stroke pre-hospital care and education. So finally, I wanted to mention this, that we last time we hosted a closed-door roundtable discussion. As you can see in the middle, Dr. Pandian was there, Dr. Anthony Rudd, and Gary Ford was there. We have a closed-door meeting to discuss the potential strategies to improve stroke pre-hospital care, especially with a focus on low and middle income countries. We published that expert opinion immediately afterwards. So I wouldn't take too much time here to go forward for our outstanding speakers' presentations. We're looking for collaborations and support. So feel free to reach me if you have a special interest into work with us to improve stroke pre-hospital care in global scale. So next, I want to hand over the moderation to Professor Gary Ford to continue the symposium.
Okay, thanks very much, Renyu. Have we got the right screen up? I can't see myself, that's the reason I'm asking. It's my pleasure to welcome our two keynote speakers, both from Australia. Australia has made major contributions to stroke care and continuing to do that in the pre-hospital domain. So our first presentation is from Steve Davis, Professor of Neurology at Melbourne University, and is going to discuss their approach to looking to providing pre-hospital care in remote communities, which is a challenge many countries around the world face. And even in the UK, we have remote countries in part of the devolved nation. So, Steve, over to you.
Gary, thank you so much, Renyu and colleague. Now, good. Okay. Well, good evening, everyone. And I'm going to present this talk on behalf of my colleagues, the co-chair of the Australian Stroke Alliance, Jeff Donnan. This research is funded by grants. We have academic industry partnerships, but no financial disclosures whatsoever. Now, the Australian stroke challenge is really illustrated by this map, that most of our population lives on the seaboard. There's vast areas of our country which are not covered by stroke units, by CT scanners, by stroke specialists. And this is basically 1/3 of Australia. The number of Australian stroke cases is going up fairly rapidly. And basically, populations in these regions don't access modern stroke care, or modern stroke care is delayed because of the time windows for thrombolysis in particular. So the approach we've used is to try and utilize pre-hospital stroke treatment to move the hospital to the patient, which has proved so successful using mobile stroke units around the world, not just in high-income countries, but increasingly in middle-income countries. And I know that there are now many mobile stroke units in China and in Thailand and other countries in Asia. So these mobile units, which contain a CT scanner, which you can see here, are basically contain a stroke team, and they move the hospital to the patients. They save time. They allow intravenous thrombolysis on site, recognition of large vessel occlusion, and acute blood pressure lowering in ICH, which my colleague Craig, I'm sure, will talk about. But the main barrier, particularly for more rural settings, is the weight of the current scanners. This is the scanner used in most units around the world. It's about half a tonne, and some of them weigh closer to a tonne. They're impractical for standard ambulances or aircraft. So we are funded for this Golden Hour program, aiming to get faster treatment for outback areas shown in this photograph here. And the major aim is to develop lightweight, portable and affordable brain scanners to deliver them in stroke smart ambulances and aircraft and link them by national telehealth with digital connectivity. And this is a large partnership in Australia, which includes entities such as our Royal Flying Doctor Service. I'm mainly going to talk about these two devices, a stroke helmet being developed by EM Vision at Brisbane and Sydney, which will weigh less than 15 kilograms, and the MicroX CT ring scanner, which is again also in advanced stages of development and weighs about 70 kilograms. So this device is about 10% the weight of a regular CT scanner. So let's start with the MicroX device. This uses cone beam CT, which is quite unlike standard CT. It's used, of course, for animal and dental radiology, and it uses unique cold cathode technology with very fine carbon nanotubes. When voltage is applied to these tubes, electrons are concentrated, accelerate towards the anode to produce photons. The essence of this technology is miniaturization of the system using mini tubes that are around 300 grams compared to the smallest mobile tubes, which are 1.5 grams, and a standard X-ray tube of around 40 kilograms. So this company has developed a high voltage array of 21 of these 300 gram mini tubes. This array weighs about 15 kilograms. And just to look at what the aim of the program is, it's to develop a head CT scanner which will be in the order of 70 or 75 kilograms. Looks like this. This is a larger prototype which we'll be testing in the hospital early next year. The company is also funded to develop full body miniaturized CT, and this is the comparative. This is one of the companies with a CT scanner where the weight is close to a tonne. It's a huge difference. Now, the images being produced to date are being tested on phantoms, have not yet been tested on patients, but these images give you an idea of the sort of resolution that can be achieved. So you can see here in standard sagittal and coronal images here, axial, I should say, coronal and sagittal images. You can see here very clearly skull. You can see ventricles. This is an arterial model that's been put into the phantom, and you can see here shown very nicely on the sagittal image. And you can see here on the coronal scan, this is a cross section of the artery. You can see that very, very small diameters in the order of 1 or 2 millimeters can be detected. Posterior fossa remains a problem with a lot of imaging artifact, and further developments are underway. So this is roughly where the technology is to date. It's somewhat better than this, but this is the published data. And the potential is to get down to 10% of the weight of the current MSU scanner using this unique system. And this is what it will look like in a regular ambulance, and this is what it's projected to look like in an aircraft. So this could be fitted either into the wall of the ambulance or onto a stretcher, and allows a standard ambulance to deploy a CT scanner, and it's light enough to go into an aircraft. So where's this up to now? Well, the prototype is being developed. We anticipate there'll be further phantom studies, and it will go into clinical studies in the next 3 or 4 months. Now, the other technique we're looking at is completely different, and it uses microwave imaging. This is a company called EM Vision, based in Brisbane and Sydney. This is their first generation device that they've called EMU, and this is their second generation first responder device. And you can see that this device, which is aimed at the mobile stroke unit environment, is 12 to 15 kilograms. Now, this doesn't use ionizing radiation. It uses low energy electromagnetic waves in the microwave spectrum, roughly in the spectrum that you use on the mobile phone. And basically the images are obtained by processing signals by antennae, which both emit and detect low energy signals in the spectrum that surround the head. And in the second generation device also involve the upper neck. Basically, pathology in the brain is diagnosed as a difference between transmitted and reflected microwave radiation. It's completely non-ionizing, it's portable, and it's very fast. And this is the frequency. So we've finished an algorithm training study which involved 300 patients about 3 months ago. And the data from this study is still being finalized. But the study involved patients with intracerebral hemorrhage, patients with ischemic stroke, healthy volunteers, and stroke mimics. And it looks reasonably good in terms of localization and distinction between ischemic stroke and hemorrhage. These are the sort of data that can be obtained. We don't yet have real-time images from the device, but the plan is for there to be images utilizing AI based on these microwave frequency perturbations in pathological brain. Artificial intelligence is used to train the algorithms, and you can see here that in the initial studies it seems to show good separation between hemorrhage and non-hemorrhage patients, between ischemia and non-ischemia patients. Now, the current state of this device, this is the helmet. The data is being obtained with a Generation 1 device, and the plan is to do pivotal trials next year in Australia and the United States, and also test the device in stroke smart ambulances and aircraft. So if we can prove that this device works, and the main aim of this technology, and indeed of the miniaturized CT, is the sensitive detection of small volumes of blood. That's number one aim, so that if we can exclude blood in a patient with a stroke syndrome, we can be confident to give thrombolysis in the field without taking them to the hospital for a CT or MRI scan. So blood detection is the aim. I'd like finally just to introduce you to a third technique, which is in its infancy. This is a device developed by the Wollumio company, which is a New Zealand-based company in Wellington, and it uses ultra lightweight MRI. It's under development. This is what it looks like. It's on a trolley. The weight is around 50 kilograms, and the patient, using a special headboard, goes into the device. The field strength's about 0.1 Tesla. You're probably aware that there are mobile MRI devices. There are two commercially available that have a slightly lower field strength than this, but weigh, again, in the order of at least half a ton. So the weight is way reduced. We, in fact, just studied our first volunteer on literally a couple of days ago at the Royal Melbourne Hospital. This is a simulated image trying to show what a diffusion-weighted scan would look like using this technique. But we have no human data to show as yet. It's just the beginning of the journey. But with a 50 kilogram field strength, we think that this has got enormous potential. Now, all of this is put together with digital connectivity, and let me just summarize and put all this together. Treatment of stroke has dramatically changed, as we know, particularly acute treatment in the last decades, and particularly with the advent of thrombectomy. But thrombolysis remains the mainstay, but sensitive detection of blood is an absolute key aim. Pre-hospital care in mobile stroke units has been shown in 2 phase 3 studies to improve clinical outcomes. Lightweight imaging devices are now required for regular ambulances and aircraft. And although I haven't had time to talk about this, these are digitally connected using apps and using satellite systems such as Starlink, using low orbital satellites that allow the transmission of this information to a remote stroke expert. So it might be a stroke expert in Melbourne looking at an image in Central Australia and advising the paramedics whether or not the patient can safely have thrombolysis. We see this as representing global opportunities to harness these really cutting-edge technologies to improve pre-hospital stroke care and reach the patients who are currently excluded in many cases from modern stroke treatment. Thanks very much for your attention.
Thanks, Steve. Absolutely fascinating progress in technology, and I think we can all see the advantages of this. We've got a minute or two if there's any immediate questions, or we can pick them up in the round table. I'll maybe just ask one question before going on to Craig. In the arterial model, was that a model of angiography, Steve, that would be able to demonstrate vessel occlusion?
Yeah, hopefully it will. LVO detection hopefully will be achieved, I think, more quickly with the CT device than the microwave device. But the main aim at this stage is to detect 1 or 2 mils of blood so that we can thrombolyse in the field. And if we can do that fast, as shown in the mobile stroke unit trials, we can improve clinical outcomes for those in rural and remote locations.
And I think that brings us nicely on to our next speaker, Craig, who's done major work in advancing our understanding of effective treatments for intracerebral hemorrhage. So Craig is president-elect of the World Stroke Organisation, follow on from Jayaraj, and in the University of New South Wales, Australia, and also has forged really effective collaborative partnerships around the world to deliver some really important studies, but particularly with China. So Craig, over to you to talk about clinical trials for stroke pre-hospital care.
Yeah, thanks very much, Gary, and Renyu and Jing and Tony for this invitation to talk about pre-hospital care from a clinical trial setting, and also want to acknowledge Steve Davis and his team for driving this new technology, and it's very exciting. I guess what I want to focus on is the translation of treatments into pre-hospital care, maybe in a more low resource setting. And the focus of my talk really is on intracerebral hemorrhage. So what Steve Davis has emphasised is the whole focus of most research to date has been to exclude hemorrhage, to focus on early treatment with thrombolysis, which we've shown really offers a lot of benefits to patients with acute ischemic stroke. But now we can also focus on the opportunity to detect intracerebral hemorrhage because we have a proven treatment which has shown this year with the results of Interact 4. So I want to expand on that trial and where do we go to take this opportunity around treatment. And I need to acknowledge all of the investigators into this big study which was done in China. So we've been working on blood pressure lowering for intracerebral hemorrhage for almost 20 years now. And 2 years ago, we presented the results of Interact 3, which was a bundle of care which incorporated blood pressure lowering with other targeted physiological control variables, and we got a positive result. But it took us a lot of effort. We had to do this trial with a cluster randomized design, 121 hospitals, 10 countries, over 7,000 patients to show a positive result. And the reason for this is that blood pressure control several hours after the onset of bleeding in the brain has a modest treatment effect. Presumably the mechanism is to tampen out the bleeding. And as we know from this pooled study of all observational studies, and most of the bleeding happens very quickly and attenuates over 3 or 4 hours. So there is bleeding that continues on over 24 hours, but most of it's up front. And so if we really want to make a difference to improving outcome for intracerebral hemorrhage, we have to start the treatment early, and has a lot of parallels for thrombolysis for acute ischemic stroke. So Interact 4 undertook this approach to treat patients with stroke within a 2-hour time window who were hypertensive. It was a focus around intracerebral hemorrhage, which has a greater frequency in Asian patients, Chinese patients than elsewhere. We thought the treatment would also have an effect on acute ischemic stroke. It potentially could accelerate the use of thrombolysis rather than waiting to control blood pressure. It may have a neuroprotective effect, and we've known elsewhere that it can reduce intracerebral hemorrhage post-thrombolysis. But the focus really was around intracerebral hemorrhage, where there would be neutral or potentially positive effects in acute ischemic stroke. We did it mainly in 2 regions, 55 hospitals in China. The eastern region is a high economic area around Shanghai and the eastern seaboard, and then in the west, mainly around the city of Chengdu, it's a lower economic region. And in China, there's 2 main models of ambulance care. In a low resource setting, it's from the ambulance comes from the hospital, and returning the patient to that hospital from a hospital number. And in the high income area, it's a centralized model, which we're more familiar with in the West. And the other unique thing about ambulance care in China compared to elsewhere is it has medical doctors in the ambulance. A lot of them are on a rotation from the emergency department from the hospital-based model, whereas in the West we have more paramedical trained office. So it was a remarkable study to have randomized almost 2,500 patients over 3 years, and they did this through all of the issues to do with the COVID pandemic, with quarantine lockdowns and everything in Shanghai at the time, and with very good follow-up with the patients and quality of the data, which was remarkable because, doing research in the ambulance, they're very naive to research methodology and quality, and then linking the research in the ambulance to the hospital to have achieved that is just commendable to all of the investigators. So the overall blood pressure parameters are on the left. The control arm, which wasn't treated unless it was an extremely high systolic blood pressure, versus the blue line, which is the intensive treatment. Using the drug Urapidol, which is very popular in China, Eastern Europe and Latin America, and not so popular elsewhere. Very effective blood pressure control. You can see here getting the blood pressure under control in 5 or 10 minutes and well sustained. The median retrieval time from the scene home to hospital arrival was 20 minutes, and within that you get the patterns of functional outcome on the right. The overall result was plumb neutral for a shift on scores in the modified Rankin scale, which was disappointing. The reason why it was neutral was that there was opposing treatment effects for ischemic stroke and hemorrhagic stroke, and the size of that treatment effect balanced itself out. So a clear harms for ischemic stroke, both in terms of death and disability, and then conversely clear benefits in terms of patients with intracerebral hemorrhage. And it's quite remarkable in the patients with intracerebral hemorrhage because their baseline diagnostic CT scan in the hospital showed a smaller volume of hemorrhage in the intervention group compared to the control group, and then subsequently less growth, but less need for surgical intervention, and less complications, pneumonia related to that. So just within a 20-minute pre-hospital blood pressure control phase translated it out into very significant effects for intracerebral hemorrhage. Conversely, though, it's challenged us in our beliefs about blood pressure control in patients who may need thrombolysis. So as Steve Davis has said, now the focus is on pre-hospital care, and clearly we have mobile stroke units, but they're quite expensive to purchase, fit out. An ambulance is about $1 million. It's probably about $1 million to man each year, and then there's significant off-road times for repairs and maintenance. So they're very popular in certain areas, but it's not a good public health mechanism for stroke to be widely rolled out. The lightweight scanners are very exciting and interesting, but again, there's still a lot of work to be done to make sure that the sensitivity is correct, and then even then I'm not sure that they will be widely available, particularly in low resource settings. I've been interested in looking at some biomarker approaches, particularly around the biomarker GFAP, and I see that we have Christian Furick, who is on the program tonight, who is a world leader in this. There are two commercially available devices on the market at the moment. The Abbott devices, iStat Affinity, which is moderately expensive to have a strip to pick up. Initially, it was for serum, so you had to get blood off and spin it down and extract the serum, but now it's available with a drop of blood. And the one in the UK is a company called Upfront that has developed a combination of strips, both for D-dimer and for GFAT. And the emphasis there is to allow detection of a large ischemic stroke with an elevated D-dimer in relationship to a large clot, and negative GFAT to exclude hemorrhage on strips, which looks very simple as well to detect these levels like a COVID test script. So again, just like the imaging work, there needs to be further research to ensure appropriate sensitivity and specificity, but then the whole logistics of paramedics or doctors in the ambulance being able to do this in an efficient manner and then to treat the patient. In both of these tests, it takes about 15 minutes to get a result, but that may be possible when blood is taken as part of the initial assessment for blood glucose. By the time the patient's ready to leave the scene, you probably get a result from GFAT. But what about the whole issue of doing research in the pre-hospital setting, the experience we had with Interact 4, and then thinking about how do we take it forward with a repeat of Interact 4 using a biomarker approach? Well, first of all, there's a lot of stakeholders and a lot of engagement, and many of the ambulance services have a very close link to government health departments, and getting approvals and explanation of benefits and risks is quite labour intensive, and one has to be very patient and go through appropriate approval trainings for that. Second issue is the training of the paramedical staff. They're on rosters, they often rotate around stations, so you could train up a crew, but they can move to another station several weeks later, and you've got to continue to do that. The third thing is there's variable perceptions over risk and benefit of these treatments. We think that we can get a GFAP sensitivity of around 95%. So that means a 5% error. To us, working in a hospital setting, 5% error, we're quite comfortable with that. We're used to that. But in a pre-hospital setting, in the paramedics, that still causes them concern. And that raises then the whole issue number 4, is that most of the time the perception of paramedical staff is retrieval and has a less skill set than doctors. And so if we're asking paramedical staff to change that role from retrieval and transport into the management of the patient, then again we have to do further training, collect data, and provide reassurance to the public over the skill mix. And then finally, the levels of informed consent, and clearly experimental treatments need a full range of consent. Things that are within the range of clinical practice in the hospital setting, transporting that out into a pre-hospital setting could work with a brief consent or a delayed consent, you could argue. It depends on the jurisdiction and the perceptions of the ethics committee in terms of the experimental treatment. But ultimately, you have to demonstrate that the treatments that you are applying are of low risk, and the treatments you're applying would be as part of routine care that you would be using in a hospital setting, for example, patients with acute intracerebral hemorrhage with elevated blood pressure. So I'll finish there and look forward to the further discussions that will follow and the presentations. Thanks, Gary.
Thanks very much, Craig. We're on time, so we'll pick up the discussion. Lots of topics to discuss there in the subsequent 30-minute time we've got for the round table. I'll just make one comment. I do more general work with ambulances, and I think it's interesting how limited diagnostic capacity there is in ambulances, and stroke is really pushing both the imaging and point of care diagnostics. So I think we're as a specialty probably really at the forefront of developing diagnostic capability in the pre-hospital setting. So I'm going to hand over to Renu to moderate the next session. So over to you, Renu.
Thank you. So our next speaker would be from Nigeria, Professor Mayowa Awolabi. He is the current chair for Lancet Commission on Neurorehabilitation. His presentation is the roadmap to improve stroke pre-hospital care in Africa countries. Mayowa, you want to share your screen?
Thank you very much. I'm sharing my screen now.
Yeah, it's coming up.
Okay. Thank you so very much for this great opportunity.
Yep.
Yeah. So we know that stroke is a major issue, and that's why we are discussing today. And that was one of the things that inspired the Lancet Commission on Stroke, which was launched last year with 4 pillars, which I will be talking about later on. We also, in the Lancet Commission on Stroke, which I shared, we looked at the projection of the burden of stroke. And you could see that for sub-Saharan Africa, both for ischemic and hemorrhagic stroke, up till 2050, the burden is expected to continue to increase in terms of DALYs. Economic losses are also going to, because we also did an economic analysis and calculated the burden, the economic burden of stroke, direct and indirect costs added together is almost $1 trillion now. And is going to be moving towards $2 trillion annually by 2050. So whatever we invest is more than worth it. So there are 4 pillars of the stroke quadrangle. Actually, this was inspired by an earlier idea about taming the burgeoning stroke epidemic in Africa, stroke quadrangle to the rescue. So 4 pillars: surveillance, prevention, acute care, and rehabilitation. Of course, hyperacute care, pre-hospital care are part of the acute care pillar. And it is good that we are focusing on this very, very important aspect of stroke care, particularly in developing countries and globally today. So we looked at the services for stroke across the globe. And if you look at the pillars: surveillance, prevention, acute care, rehabilitation, you will see the disparities in terms of the services, quality and quantity of services available for acute care across different world regions. And of course, you see that Sub-Saharan Africa seems to have the weakest system. So a lot of work needs to be done in Sub-Saharan Africa. That's what we have been talking about today. But again, when you look at LMICs generally, we looked at stroke guidelines and saw how they are attended to the 4 pillars of the stroke quadrangle. Surveillance was not really attended to by most of the guidelines. Primary prevention, secondary prevention was attended to. But when you look at acute care, you would see that for low-income countries and middle-income countries, there is a gradient in terms of the quality of care, which is best in high-income countries. Of course, we do our best to prevent stroke, but when stroke occurs anywhere across the globe, whether rural or urban setting, we want people to have the best chances of recovery and rehabilitation. And that is the essence of what we are discussing today. So across all the pillars, of course, we had recommendations, which all of you are probably familiar with. Now, for the acute care pillar, the critical elements of intervention we are all very familiar with is thrombolytic therapy or thrombectomy. And these are all time-dependent therapies for for ischemic stroke. Of course, for hemorrhagic stroke also, thanks to Craig Anderson for his talk. Also, acute care, hyperacute care are also extremely important. Now, before I go on, I really want to mention that while in the high-income countries in the Northern Hemisphere, ischemic stroke is almost 80-90% of cases. In Africa, up to 33% or even more are hemorrhagic stroke, and that's really very important. But again, that's still time dependent in terms of care to get the best. Also in the young, using the Siren study, which is the largest study of stroke in Africa, we found that 52% of young patients actually in Africa have hemorrhagic stroke. So that's important. So this for ischemic stroke, of course, those are the key things. This has been mentioned by Gerard, who was very, very instrumental and supportive of the Lancet Commission on Stroke. And this is part of what we came up with: minimal stroke service, essential stroke care, advanced stroke center and all of that. But for all of this, it's extremely important to have hyperacute and pre-hospital care. So we analyze the different barriers. I will not be able to go into details about this, which applies to Africa and other LMICs, and facilitators, and how to navigate those barriers and facilitators to improve hyperacute pre-hospital and acute care services. So, looked at service provision, we looked at funding, we looked at workforce, which is a major challenge, we looked at technology, we looked at governance, and we looked at data and information. So, but I will illustrate with just a few of those points for Africa. Pre-hospital care, the main issues are lack of stroke helpline, insufficient infrastructure, unavailable or inadequate transport facilities. Traffic jams are also an issue. So we also did a survey that covered 45 countries across Africa. There are 54 African countries. So we covered 45 countries, both Francophone, Anglophone African countries, on different aspects of stroke systems of care in Africa. And you would see that dedicated emergency stroke helpline is non-existent for more than 90%. Emergency medical service, generally speaking, is also non-existent for more than 50% of cases. Yeah, and of course, medicalized ambulances are also not available. And these are the key critical elements of acute stroke care or pre-hospital care. So, Dr. Nidu, time, what is the goal? The goal is that we want people to present the very few minutes after they have a stroke. We don't want people to have stroke. But when they have a stroke, we want them to get to us within minutes if possible. But at least in terms of setting targets, we want 50% of patients with ischemic stroke or even hemorrhagic stroke to get to us within 60 minutes as much as possible. And of course, that requires emergency medical service. Activating the stroke team is always going to be a team-based approach. Emergency medical services are poorly developed in Africa. And in fact, emergency medical services are established in only 16 African countries. Most of them are government-operated, fee-for-service, and poor uptake, just generally speaking. Pre-hospital delays in stroke presentation in Africa is very common. Why? Because of poor stroke knowledge. People are not even aware when the stroke has occurred. And then secondly, even when they know, the 60-70% from the Siren study, 60-70% of people would have patronized unorthodox caregivers, faith healers, traditional healers before coming to the hospital. And even when they go to the hospital, they don't go to the right to get treated. So for 71%, and then in terms of transportation, to get to the nearest hospital where care can be given takes about 2 hours. 2 hours is already lost for 71% of Africans. Poor availability, lack of ambulance services, absence of trained first responders, paucity of neuroimaging services. Okay, so once we know the challenges, of course, we can prefer solutions to those. And we know time is extremely important because every minute we know that 2 million brain cells are being lost. And be fast and fast are very important for spotting a stroke and for educating people about stroke. And I'm going to talk about a program that is funded by the NIH, ARISES project, in which we have established a stroke information and surveillance system. I will talk about that later on. So in Africa, the median time from stroke onset to hospital admission is 31 hours. And that's really very long for any intervention that we might want to give. Pre-hospital emergency medical services provided by relatives, security agencies, and bystanders. And so we need to really train a lot of people, including paramedical staff, including task shifting to people who can give support. Now, if someone has a stroke, what will they do? Or, well, not even a stroke, emergency. If they have a medical emergency in Nigeria, I mean, this was 2019, things have changed a little bit, but a lot still remains more or less the same. 18% will call a doctor, and 42% will drive or borrow a hire a vehicle to the hospital. 36% will call someone nearby, a family or friend, to help. Only 3% will call an emergency service. So, and we're trying to, even with the ARISES project, we're also trying to have a stroke hotline. So what are the, summarizing the challenges: lack of awareness and knowledge, socio-demographic and cultural factors, healthcare system and infrastructural challenges. And this can be broken down into low recognition, limited awareness of thrombolytic therapy, and even unavailability of thrombolytic therapy, which we are also, because if people get to the hospital, they can't get a CT scan immediately, they can't get thrombolytic therapy, is actually a disincentive. So we are working around the clock to ensure that some of these challenges are dealt. So in several surveys, you will see these challenges in different countries, which I had already summarized: knowledge of stroke warning signs, financial difficulties, cultural factors, low awareness of thrombolytic therapy, and so on and so forth. No concrete translation of stroke protocols to limited due to limited resources. We know what to do. There are geographical barriers, there are no resources or limited resources, and that's an issue. But we must let everybody understand that if you save a minute, you are saving a lot. You know, just saving 1 extra minute of getting the patient to have TPA when that patient is eligible for TPA adds extra healthy lives, you know, to patients. So what are the things we need to deal with in the sequence? Detection, very important, including lay persons to be able to detect. Dispatch, and we have a stroke video that we have developed from the Lancet Commission work, part of that which we did in Nigeria, but more importantly also from the Siren study, dispatch, delivery, door, data, decision, drug, disposition. So this is what happens pre-hospital as well as hospital. And in fact, some of what is happening that happens in the hospital can actually happen pre-hospital, including thrombolytic therapy. So all of these are very important. So diagnosis and interventional strategy at the community level, and then using technology and innovative approaches, training the trainer, educational campaigns from the African Stroke Organization conference. We've been doing this. We had the 4th conference in Zambia this year, was attended by the Minister of Health, policymaker from Nigeria, as well as the one from Zambia. We're engaging all stakeholders. So mobile stroke unit, portable transcranial ultrasound, telemedicine, some of these have been spoken with about eloquently by Stephen Davis, and I really must thank him for all of that. So mobile stroke unit, telemedicine, using AI, mobile point of care imaging devices, both portable MRI as well as portable CT, which is still being experimented with, and EMS systems, and of course, stroke ambulance with almost like a full-fledged stroke unit inside. Even though these are very, very expensive, may not be deployable in low and middle income settings, but other things can be done. So, but we need to leverage technology, use digital solutions, social media for education and awareness, provide affordable medications, demographic and geographic approach, affordable technology solutions, and cost-effective educational campaigns. All of these are very important for the family, for the patient, and then providing emergency services. We may be integrated into regional, national, or international emergency services. So all of these are very important and these are different models of the stroke rescue chain. As I earlier mentioned, some of what was done in the past in the hospital can actually be done pre-hospital using stroke ambulances. I will not be going into details about this. So the stroke emergency mobile unit can offer a lot. So like I mentioned, spontaneous intracerebral hemorrhage is extremely important, and early intervention is also equally important. These are some of the care pathways. So telestroke is really going to help, especially when the workforce challenge is immense as it is in Africa and other LMICs. We can leverage the WHO IGAP, the Neurology Revolution, and the Global Stroke Alliance, and all of the great things that WHO is doing to really bring a step change. But this requires an ecosystem that involves implementation partners. MT 2020 Plus has been doing a lot. Of course, CSTS today, congrats to everyone, has also been doing a lot. The AGS initiative has been very supportive in ensuring that acute care receives a boost across the globe. But we shouldn't only focus on policymakers. We should focus also on the patients, caregivers, general population for education, for the early recognition, early presentation, payers and funders to fund proven interventions, and of course, leverage on our connections and interactions with WHO, World Health Assembly, World Bank, and so on for funding. So we need an holistic system that takes care of whole of government, whole of society approach to ensure that we prevent stroke, but when that's not possible, people get care almost immediately where they are, because every minute really counts. So it's the stroke information surveillance system, which we set up under the RICES as African Rigorous Innovative Stroke Epidemiological Surveillance System, which is currently ongoing. So we have a stroke information and surveillance system, which involve the community with community advisory board, geotag, demographic surveillance site, spatial data. So we have a stroke finding system and a stroke alert system, and that is already improving acute presentation. So time is very critical. There are key strategies, pre-notification, activating a stroke team, rapid brain imaging, and that can be assisted, God willing, over time with things like portable MRI, for the brain, portable CT scan systems, EMS, which maybe have been developed, and with AI to help with interpretation, and telestroke to help with decision making, and of course with thrombolytic therapy available to help with immediate intervention. Stroke emergency mobile units where you can offer a lot of this care, and of course guidelines, on pre-hospital care. And like Gerard had mentioned, whatever is recommended to communicate from today's meeting are part of what can be integrated into the guideline. So those are the key strategies. Some of the activities in Africa to control hypertension, and of course the African Stroke Organization Conference we have mentioned, and training programs, including for scholars in research, in data science. And right now we are also working on the Lancet Commission on Neurorehabilitation, to which some of you are members. So I really want to thank everyone who was part of the Lancet Commission on Stroke, more than 322 commissioners across 84 countries, 224 co-authors, and thank you so very much for this opportunity. Happy to work with everyone to ensure that we are able to raise the bar and improve lives for everyone. Thank you.
Yeah, thank you very much. Outstanding talk. Because the time and invitation, we'll have a dedicated discussion at the end of the symposium. So next, I would like to invite Dr. Amida Kendall from University of Buffalo. He's director of the Stroke Center there. He's presenting Organizing Pre-Hospital Care to Reduce Inequities in Access to Acute Stroke Care in Western New York. Yep.
Okay. Thank you, Renu, and thank you for this privilege. It's amazing privilege for me to be presenting this talk with all the esteemed leaders in stroke and pre-hospital care. And it's a really difficult task to follow after Myoma's presentation, but I'll try my best. So I am a stroke neurologist and a stroke director in Buffalo General Medical Center, which is one of the comprehensive stroke center in Western New York. And it's the busiest stroke center in New York State. I do not have any disclosure. So my goal today actually is what I have been trying to do for last 1.5 years, to make a story where I can advocate for better support from policymaker, from EMS provider, from patient and caregiver group. Stroke is a political and social disease as well. And pre-hospital care has even higher component of political determinants. When we look at even a high resource countries, there are urban and rural hotspots. And we do feel that telestroke is the antidote for rural hotspot, whereas the mobile stroke unit could be an antidote for urban hotspot area. But I'm going to do my presentation today without using telestroke, mobile stroke, or AI. It's just about a storytelling. So if you look at this slide, this is the stroke burden, stroke prevalence. And this is the city of Buffalo, which is the Erie County, which is on the western part of the New York State, whereas this area is the metropolitan New York City. And you can see in this picture as well that the stroke prevalence is more in non-metropolitan city. Then if we look at the stroke death rate, which combines both hemorrhagic and ischemic stroke, so stroke death rate per 100,000, all races, ethnicities, all gender is 35 plus. There is a huge disparity, especially in the Western New York. The death rate is almost double when we compare with the metropolitan New York City area. In hotspot analysis, there is a clear-cut cold spot in those areas. So we were trying to figure out how can we explain this trend. And first thing that comes to mind is, okay, let's look at the number. When we look at the number, the death rate is almost double. If we compare, it's 35.2 in New York County, whereas in Erie County, it's 68. And similarly, the rates are different in races and ethnicities as well. When we look at the socioeconomic data, actually the data looks opposite. There are more white non-Hispanic in Erie County. Less people are under the poverty line. More people have insurance. Even despite those economic and social advantages, still the outcome is much worse in Western New York. Then we looked at the data, same data, with overlay of a stroke center. And it clearly shows the difference that this area has highly concentrated or lot of stroke centers or access to care. Whereas if we look at this area, there are 2 comprehensive stroke center and a primary stroke center. Then we looked at stroke death rate and hospital with neurological service, and we again see the same trend. The area where the outcome is better, there are more hospitals with neurological service. And if we count emergency, tele-stroke, and neurological service, again, the same disparity stays. So when we look at the risk factor, I just took the example of high blood pressure and smoking status. Again, it's the same pattern. Wherever there is a high stroke death rate, high stroke prevalence, there is a higher prevalence of stroke risk factor as well. And in New York State, we look at the GVD database, almost 50% of population attributable risk is due to high blood pressure. 68% is related to metabolic risk cluster. So to summarize, we have urban and rural hotspot, and now we know that the main problem is access to care, access to neurological service, even in high resource area. So we wanted to address this in 2 major ways. One, how can we improve a community outreach? And second, what can we do to change our EMS service? Now, community outreach, there were a couple of things that we realized. In 2023, in 1 quarter, when we did the quality assurance project, we looked at people coming to our hospital who did not come within 4.5 hours window. So anyone coming from 4.5 hours to 12 hours, when we looked at those numbers, there were times when 35% of people in that group came to the hospital in a private vehicle. They did not take ambulance to come to the hospital. So we realized that even if they are aware of the symptoms, the FAST campaign works really well. They are aware that those symptoms are related to stroke, but there is a wishful thinking that they delay to come to hospital. And then if they decide to come to hospital, they are not using ambulance service. And if they don't use ambulance service, then the pathway of care doesn't work. So we decided to work with the community leaders. So we established a health equity ambassador program. And the idea was taken from LA barbershop program. So we selected 20 health ambassadors who are trained in high blood pressure management, blood pressure awareness, and we included stroke as part of their community outreach. And we feel that this program will be able to reach the urban hotspot area where we can improve the awareness of stroke symptoms and also the blood pressure control. So we decided to target 2 areas. Then similarly, we also established after COVID. Before COVID, we had a very strong stroke survivor group meetings and those. And then because of COVID, that had stalled. And we restarted it from the April. And this has been one of the biggest success because now we have the people with the lived experience going to the community and helping us to make a stroke awareness campaign better. And similarly, we're focusing on the regional refugee clinic as well as community radio service. Then the second thing that we did was to bring all the health system together. Now, it's easy to tell EMS that they all should be looking for stroke symptoms or stroke management. But in Western New York, only 2% of EMS work is related to stroke. And in the rural area, most of the EMS provider are volunteer and they have a 6 weeks of training and they do the EMS service. So we don't have that much of opportunity to train them about everything related to stroke. So we decided to focus on few value-added things. That value-added thing being BFAST. And if BFAST is positive, then we wanted them to do the FAST ED. So as a group, all the health system and all the ambulance service in the Western New York, we came to one place and approved BFAST and FAST ED to be our stroke screening and stroke severity tool. And then we started focusing on pre-notification. So there are more than 10 health systems in Western New York, but they use different EMR. So one of the biggest barriers when they come to the hospital is we do not know the past medical history and the family are not coming in the ambulance and they are driving. And if we don't have the phone number to contact the family, then that delays the treatment. So we started the pre-notification program, and that pre-notification program has to include a family phone number so that even before the patient comes to the hospital, we can talk to them, we can get the history, contraindication, and we are ready to manage from the triage area. And then we also established a common training program so that we don't have a redundant program by different health system. And our result has started to kind of look different. Now, this is our dual to needle time for all the eligible thrombolysis within 30 minutes. And except 2 months from last 1 year, we have been able to give thrombolysis within 30 minutes. And one of the biggest factor is pre-notification. On average, 65% of people who are eligible are getting thrombolysis within 30 minutes. If we look at all the people who are coming, irrespective of contraindication for 30 minutes or delay because of the medical history, even those numbers are looking better. And this higher trend is the dual to needle time, which is going down. And then we started to look at onset to needle time. Dual to needle time does not do service to pre-hospital care. And if we want to look at the quality of pre-hospital care, then we realize that onset to needle time is the key. And those numbers are also looking better. So this is the story that I am taking to my hospital administrator as well as the policymaker, because the key is having a right policy to improve the pre-hospital care, including community outreach. Thank you. Thank you so much for your attention.
All right. Thank you very much for your talk. Again, we're gonna continue move along. Next, we're going to invite Dr. Jin Zhao. She's the current co-chair for the World Stroke Organization Task Force of Pre-Hospital Care. She's presenting Establishing a National Network for Stroke Education and Improvement. Dr. Zhao, you can share your slide.
My topic is about establishing a national stroke education organization aims to improving the quality of stroke pre-hospital care. And as we all know, vascular recanalization is the most effective method for treating ischemic stroke. And in the past 20 years, the Chinese government has taken a serious measure and actions in order to improve the recanalization rate of blood vessels. And first, what we do is to train doctors through a serious measures to improve their technology. And that does work in hospital and tend to be super in resource limited secondary hospital. And after we took at this program, we know that we found that the delay time in the hospital was still very long. So we studied the quality improvement in the hospital, shortened the DNT time within the hospital. And this project has also achieved great success. But even though our technology has improved, the time within a hospital is reduced rapidly. Our thrombolysis rate still can't be improved. And in China, the thrombolysis rate was still 5.64%. So we turned the subject to the pre-hospital, and we began to get through the efficiency of the emergency center. So now, with the improvement of the level of economic development, as well as the increase in the number of emergency vehicles, the majority of patients can arrive at the hospital within an hour. And the time when the patient arrived at the hospital door from the onset still up from the onset to the hospital door, still up to 24 hours. Then when we remove the 1 hour of the transportation, there's still 23 hours from the onset to call the emergency number. So we think the most critical factors that really affect the improvement of survival rate is from the onset to action. So based on this, we believe that awareness is the key to recognize the early symptom of stroke and acting immediate. And based on the successful experience of FAST in Western countries, we launched Stroke 120 in 2016. And when we promote this program, and we have the government strong support through the stroke linked to 120, the unique emergency number in China. It's the stroke plus emergency number concept. And then we turn the number 120 into 3 actions for stroke rescue. And this is no need to understand English, easy to elderly and the children to remember. And finally, through our promotion, and then in the end, we reduced the pre-hospital delay of stroke. And in this promotion, we launched this action through three ways. The first, through the training of the doctors by the health administration department. After the training of the grassroots doctors, they enter the community to conduct extensive community publicity. And the second level is the wide regional covering of traditional media and the social media. And then the third level is the education system. And then the Stroke 120 emergency knowledge was put into the school classroom, and through students passing the knowledge to their parents, grandfather, and grandma. It has promoted the first aid knowledge of the whole family. This is the process of our entire community doctor training and community outreach. And then the all process is recorded. And this is the trained community doctors enter the community to educate residents. And this is the Stroke 120 video for coverage in public places in our regional. And the Stroke 120 entering 126 primary and secondary schools and passing Stroke 120 to their families through children. And at the end, we reduced the pre-hospital delay of the strokes significantly in our region. The pre-hospital delay time from 18.72 hours to reduced to 6 hours, and the rate of hospital arrival within 3 hours from 5.8% to 33.4%. And we also decreased the average length of stay in hospital from and reduced hospitalization expenses of stroke patients. Although we have made remarkable achievements in some areas by looking at of the whole country, the situation of the pre-hospital delay is still very serious. And even though in Henan, Zhoukou, the area, they have made a great success of the in-hospital survivability improvement, but the pre-hospital delay is still a major cause of low reperfusion rates in stroke. So we established a national education organization aiming to improve the pre-hospital care, and there are 125 hospitals from all over the 31 provinces across the country attend. So this is the first one in China, a special committee on pre-hospital committee to improve the pre-hospital quality. So our first task is to carry out extensive public education on stroke 120, a national multi-center study aimed at reducing pre-hospital delays. So our primary focus, primary endpoint is to reduce the pre-hospital delay. So we will select 32 sub-community centers around the country, and then we will this is our study procedures. And the pre-hospital delay is a big barrier in stroke care. So we would like to obtain all of you support us, and let's work together to reach the goal. Thanks for your attention.
Thank you very much, Dr. Zhao. Outstanding presentation and outstanding work to establish the network. So again, Karen, are you ready? So we welcome the next presenter from Mexico. The title presentation is to compare the effectiveness of the Stroke 911 in Spanish with other stroke awareness tools in Mexico. Karen, you can share your slide. Yep.
I'll do my best. It is an honor to be here among such esteemed individuals. Thank you very much for this opportunity. So I'll present this work titled Trial to compare the effectiveness of Stroke 911 in Spanish with other stroke awareness tools in Mexico. So stroke, as we know, is the leading cause of death and disability globally, and the second leading cause of dementia. Affecting 1 in 4 people worldwide, as we know. So the effective stroke treatment relies heavily on time, often refers, as you already mentioned, time is brain. And despite this, the general population awareness of the stroke symptoms is alarmingly low, especially among, Hispanic adults who have similar stroke rates to their non-Hispanics counterparts. They are less aware of symptoms and how to respond to them, or what to do in those situations. And we know the acronym FAST, and it's been widely used to educate the population in early detection of stroke symptoms, with great success since its introduction. It specifies 3 symptoms with a high positive predict value for stroke, which are facial weakness, limb weakness, and speech difficulties. FAST has proven effectiveness, yes, in English-speaking countries. Nevertheless, its implementation in non-English speaking population has faced challenges, showing much lower efficacy compared to English speaking countries. Up to 2024, up to 2024, had been at least 4 proposals for the literal translation to Spanish. We have the literal translation fast into rápido. We have dale, which is give it. We have corre, which is run. And we have camaleón, which is chameleon. These are the ones we have for Spanish speakers, but they are not as good as fast for English speakers. And then we have an additional stroke awareness strategy that does not attempt to translate the FAST acronym, but has been translated from Chinese, which is the Ictus 911 strategy, the Stroke 911 strategy in Spanish. And unlike previous strategies, is not based on the literal translations of the FAST, but rather emphasize the critical warning signs of a stroke and the need to call emergency services if any of the symptoms are identified. Its advantages are that it is brief, easy to remember without technical language, and refers to the emergency phone number used in many countries. However, this is one of its limitations too, because this does not apply to countries where the number is not used. So we need steps for a potential solution, right? We have to acknowledge the problem, create consensus, create a new proposal, and test the performance. So therefore, in this trial, we aim to measure each study performance and compare their efficacy in increasing stroke awareness in Spanish-speaking adults. So this is a randomized clinical trial to test the efficacy of this existing translations of FAST to improve stroke awareness in Spanish, and the stroke 911 strategy. What we did was to the stroke knowledge was evaluated using the stroke awareness questionnaire, and we have we did the questionnaire, we have an intervention, and a week after that, we applied the questionnaire one more time. We have the primary outcome, which is the change in the proportions of the items in the SAQ symptoms domain after the intervention. And we have secondary outcomes. The first one is the change in the proportion of participants achieving the adequate level of stroke knowledge after the intervention, and the change of in the proportions of patients taking the correct or appropriate action after identifying stroke symptoms after the intervention. For our sample size of this study, we used Cohen's effect size classification to find an effect of 0.50. To achieve a significant result, we need 64 participants per group. However, as this is studied with 2 evaluations, we anticipate a 20% loss of participants in the second evaluations. So at the end, we will need at least 65 participants per group. The participants' knowledge and perceptions about stroke with the ASAQ questionnaire, transient ischemic attack, and related conditions. When asked about their understanding of a stroke, 16.8% of participants reported not knowing anything about it, and while 14.9 responded correctly. So knowledge about transient ischemic attack was limited, with the 92.6% stating they did not know what it was, and only 2.5% provided an accurate definition. This proportion was consistent across the groups. About the risk factors, the participants identified multiple stroke risk factors, with stress, diabetes, and lack of exercise being the most frequently mentioned. The number of identified risk factors was low overall anyways, so with an average of 1 risk factor per participant. The awareness of stroke symptoms was similarly limited. Weakness of one side of the body and slurred speech were the most recognized symptoms, and only 57.7% of participants mentioned components of the FAST mnemonic. Regarding perceptions of this disease severity, when asked, stroke and cancer were most frequently rated as the worst imaginable condition. About the primary outcome, overall, not a statistical significance difference were detected across all symptoms and groups. The most substantial improvement in the proportion of identified stroke symptoms were observed for facial weakness or fallen face recognition, with increase up to 0.49 in the chameleon and ictus 911 groups. The recognition of slurred speech and weakness on one side of the body also improved significantly across all the groups, and in the highest group was ictus 911 group. And the recognitions of the symptoms in the FAST acronym varied, with the highest increase in CORRE group. In contrast, symptoms such as shortness of breath and problems with vision saw minimal changes. About the secondary outcomes, we have some difference here. We are presenting the proportion symptoms identifying pre and post intervention by groups, being the blue bars the pre-intervention, and the orange or red, I think, bars the second or the post-intervention group. And you can see how the population increased the recognition of the symptoms in all the groups, being one more time ictus 911 with the highest recognition. So about the secondary outcomes, the change in adequate stroke knowledge, the first outcome, the ictus 911 intervention demonstrated the most significant improvement in proportion of participants. This achieved 31% of increase, followed by chameleon with 22% increase. And Rápido, like the literally translation of FAST acronym, has the lowest increase with 9% increase. The proportion of participants taking the appropriate action after identifying stroke symptoms increased constantly from 12% to 17% for Chameleon, Rápido, Dale, and Corre strategies. However, one more time, ictus 911 demonstrated to be like the most increased one with 29% increasement. So it was significantly higher. About our conclusions, well, there were no statistically significant difference in the primary outcome. All the studies increased the number of identifying symptoms after exposure, but the stroke 911 study was better at increasing the proportion of patients with adequate stroke knowledge, and more importantly, at increasing the proportion of patients taking the appropriate action, which is, I think, the most important thing to do about this, or the most important thing we wanted to lead to the participants, what actions to take after they identify the symptoms. So we have to do some efforts to humanize stroke symptoms and identify the strategies much needed in Spanish speakers speaking countries, preferably using, now that we check in this study, a stroke 911 strategy.
Next presentation will be from Dr. Hitoshi Fukuda.
Yes.
From Koichi University Hospital in Japan. His presentation is impact of municipal social status on pre-hospital delay in acute ischemic stroke patient. Dr. Fukuda, proceed. Thank you very much.
Okay, so nice to meet you, everybody. I'm Dr. Hitoshi Fukuda, neurosurgeon from Kochi, Japan. Today, I'm going to talk about impact of municipal socio-economic status on pre-hospital delay in acute ischemic stroke patient. So the early arrival to the hospital is very important in acute ischemic stroke. So what is the cause of pre-hospital delay of ischemic stroke? Actually, there are two major categories. Obviously, there is a patient intrinsic factors. For example, the mild symptoms and no motor weakness associated with pre-hospital delay. But recently, the environmental extrinsic factors of the patient have been more focused, such as bystanders' reaction and poor friendship of the patient. So we were wondering whether socioeconomic factors of the community, which is a more comprehensive factor of the patient environment, are associated with pre-hospital delay. We use Aerial Deprivation Index, ADI, as a representative of socioeconomic status of the community. This means how much money is lost because of poor human-to-human and human-to-service relationship. So higher ADI means socioeconomic disadvantage. This ADI can be easily calculated by the Japanese census, and this calculation includes several social disadvantageous factors such as old couple households rate and unemployment rate. This map shows the distribution of aerial deprivation index of all the cities, towns, and villages of Kochi Prefecture, where the white indicates a better socioeconomic status, while the dark gray indicates poor socioeconomic status. Actually, we excluded capital Kochi city from this analysis because this city is the only metropolitan area of the Kochi prefecture. So the situation is totally different from other cities and towns. I'll show you the study design. This is very simple. The target population was almost 6,000 acute ischemic stroke in all Kochi registry for 7 years, and we investigated the association of higher ADI of the community the patient resides in with delayed hospital arrival over 4 hours by multivariable logistic regression analysis. Now, this is a main result. As you can see here, higher ADI was associated with pre-hospital delay over 4 hours, and as a consequence, the higher ADI was also associated with poor outcomes, such as in-hospital mortality and being discharged to nursing facility rather than going home or going to rehabilitation center. This is our result about the patient behavior at the stroke onset in terms of emergency medical service use. This is surprising, but the patients from the higher ADI communities used emergency medical service more frequently. However, the activation of the emergency medical service tend to be delayed overnight. So this is a kind of a paradoxical and unreasonable reaction of the patient, because higher ADI patients do know that they have to activate the emergency medical service, but they don't know they have to do that immediately. And this is a result about the association of higher ADI and opportunity for RTPA thrombolysis and vascular thrombectomy. As you can see here, the patients from the higher ADI communities have the equivalent, the similar opportunity to undergo the thrombolysis and thrombectomy. However, their arrival, their treatment tend to be delayed over 2 hours. So why the higher ADI, I mean the socioeconomic disadvantage increases pre-hospital delay? There are several possible explanations, but one of them is a kind of a hypothesis that the less diverse information by closed social network may lead to a normalcy bias. This left side figure shows the closed human network in poor socioeconomic communities. Here, as the stroke onset, when the patient family, one of the patient family says, okay, you're worse, but you will get better overnight. Or the other says, I don't want to bother neighborhood. I don't want to bother neighbors. So in such a case, you may lose the opportunity to go to the hospital earlier. However, in this, can you see the right figure? This is a kind of an open human network in a better socioeconomic status community. And now, because of the diversity of these human relationships, somebody around you may say, "Oh, this may be stroke," or "Okay, go to the hospital immediately just in case." So you will have more chance to go to the hospital early. So let me show you the future social approach to reduce pre-hospital delay. Educational campaign targeting more socioeconomically disadvantageous areas rather than mass education is important. And the message included in this campaign should not be call emergency service, but call emergency service immediately without waiting until next morning. And the collaboration with the Kochi Prefectural Office is ongoing. Thank you very much for your attention.
Thank you very much. Interesting study. All right. So, Dr. Guo, are you?
Yes, I'm ready.
Are you ready? Okay.
Yes.
You can share your slide.
Okay. Good morning, afternoon, and evening, everyone. I'm very honored to be here at this international symposium on the stroke pre-hospital care. On behalf of the Xinwu Hospital and the National Engineering Research Center for medicine and health, I would like to show our work here. Today, I would like to talk about the 5G mobile stroke unit network establishment in China. We'll show our talk in four sections. Firstly, let's begin with the facts on pre-hospital stroke care in China. Nowadays, stroke stands at the leading cause of health loss in China, and the disability adjusted life years increased by more than 1/3 in the past decade. To make matters worse, the previous data from the global burden of disease suggests that China has witnessed the second most pronounced increase in the age standardized incidence rate of ischemic stroke. And between 2019 and 2020, the overall IVT rate in China was less than 6%, which less than a third of Germany or the United States. So what's the reason for such a low treatment rate? As we know, the intravenous thrombosis for ischemic stroke is highly time-dependent, save a minute for the treatment, save a week of health life. Unfortunately, in China, there were merely less than 12% of patients couldn't arrive at the hospital within 3 hours after symptoms. Pre-hospital delays set many barriers for early treatment. To treat this problem, the German professor Fassberger developed the idea of the mobile stroke unit, which is equipped with a small CT scanner and the relevant diagnostic tools in the ambulance, which enable diagnosis in pre-hospital setting. Best MSU, a multiple center pre-hospital study from the United States, demonstrated that the efficacy of MSU is saving time about 30 minutes and improving functional outcome. Despite the amount body of the research concerning MSU worldwide in recent years, the application of MSU in China is still in the infancy. So what should we do to establish our mobile stroke units network in China? Next part. In China, we implement about system named 1+30+N structure of the mobile stroke unit network with the standards for 1 national medical center, 30 provincial centers, and the numerous regional centers. The purpose of the region is to strengthen regionally linkage and improve service coverage capacity. As illustrated in the right picture, now you see since 2019, the National Engineering Research Center for Telemedicine and Telehealth has established a total of 24 mobile stroke units in 16 provinces. The project also had got the fund from China National Science and Technology Major Project. We have also developed dedicated data management and quality control system for the mobile stroke unit with a total of more than 4,000 cases of emergency service. This is the international outlet and external experience of our minimized MSU. Our self-developed 16-slice mobile CT scanner, smaller in size and provides space for vehicle minimization design with overall length less than 6 meters. It's flexible and lightweight and suitable for a wide range of road contributors. In order to evaluate the operational efficacy of the 5G MSU in China, we retrospectively enrolled patients with suspected stroke and attended to our 16-slice MSU between 2019 and 2022. After the exclusion of ineligible records, we actually include the patients less than around near 1,000 into the analysis. Here we show in the table the median age of the participants around 65 years, and the male contribute to the predominant gender at 57%, and most patients had a moderate stroke with median NIHSS stroke score around 7, and around 1/4 of the patients harbored a prior history of stroke. And in terms of the diagnosis, around 681 patients were confirmed to have acute ischemic stroke, with 244 had intracranial hemorrhage, and also we have around 5% patients required further calculation. Among patients diagnosed with AIS, 423 patients received IVT, whereas 46 underwent intravascular therapy. There was significant gender and age disparity in the administration of IVT, with male patients and those under 8 years of patient likely to receive thrombosis. In terms of the time parameters, it took a median around 50 minutes to make an emergency call after onset, and it took 40 minutes to arrive at the scene after alarm. The CT scan was completed soon after MSU's arrival, and then it took a median of 10 minutes for therapy. It was noteworthy that the time from emergency call to therapy reached a median of around 1 hour, and the time from onset to treatment was around 2 hours. We selected 6 relatively well-established MSU services center and show that in this picture, playing the role of the regional center, the surrounding by other primary stroke centers. We also compared the time parameters between regions and found significant regional disparities, mainly in treatment rate, which remind us that the strengthen the homogenization of the network is in the future. We first analyzed the cold needle time variators across the age group, and the elderly patient were more likely to receive IVT earlier after alarm the younger one, and female or the patient admitted during the daytime or on weekend exhibit shorter CNT, the cold needle time. Last but very important, we examined the halfway rendezvous transport, just like face-to-face. The MSU and the ambulance showed a trend that the shortened CNT, cold needle time, compared to the direct transport. In Suzhou, Anhui Province, we adopt a novel rendezvous transport strategy for patients located more than 30 minutes from the MSU service center. The recognition depends on the spatial distribution of the EMS station, which dispatched a standard ambulance for initial care and fetch the patients to upcoming MSU rather than staying in place. We found halfway rendezvous transport significantly shortened the CNT time from 43 minutes to 34 minutes, and show a higher rate of AIS recognition and associated with a high 1 hour CNT. This also gives us the confidence to further application of this approach in other settings. In cooperation with the previous MSU researches, our process parameters was generally consistent with the relevant data reported previous, and there remain a relative low rate of EVT and time to puncture, which may be attributed to the in-hospital procedure. Have a summary. While innovative 16-slice mobile stroke units have advanced diagnosis and treatment, workflow refinement is crucial, and age, gender, make also along with regional disparities, and also we need to do more to try the halfway rendezvous concept to offer promising strategy. Inspire the innovation solution to address the challenge faced by healthcare providers in management emergency, and also we need more help from our group and from all of you, the professor and specialists. That's all. Thank you.
Thank you very much. Outstanding talk. So next, we're inviting a presentation from Brazil through video. The use of AI for predicting outcome in pre-hospital stroke care and research. Play this video here.
Hello everyone, my name is Aaron, and outcomes in pre-hospital stroke care. Artificial intelligence can find or computer program that mimic thinking. The machine learning is a subtype of artificial intelligence in which the algorithm learns from the patterns in the variable inserted in it. And we also know that the binomial human algorithm is usually superior to the human alone or algorithm alone, although there are some very, especially when the human factor is not trained. Big data, which is a term that has been from several decades now, is the amount of data that could not be analyzed via traditional statistical methods. It is very important to use artificial those kinds of data that you can find a pattern and analyze it best. It is particularly useful in multicentric studies, the use of medical records, precision medicine for the outcome for each patient, and also the Internet of Things, in which you use variables from several collected devices, not only related to medical variables. like your way of life, your television, mobile, etc. In hospital data alone, 150 exabytes have been generated up from 2011 to 2022. It is important to notice that we are in the fourth wave of the digital health, includes precisely the big data, AI, the data analytics, and also the decentralized collection from all variables from all kinds of sources, like the Internet of Things that we see. It is also important to notice that we are currently in the peak of inflated expectations with the large language model algorithms being released, like the ChatGPT, Gemini, Copilot, etc. But eventually we will reach the plateau of productivity in which will be more ground-based and having the best results based on the reality of what the algorithm can actually do, and not have an hyper expectation that do not have basis on reality. Just very quickly, since we have time, the types of AI can be divided in methods in supervised, in which label. For example, you want the AI to predict what is a cat. Then supervised, which you do not give the label and the algorithm needs to figure out for himself what is the pattern inside variable. It is very useful to divide in categories the variables data. Semi-supervised, very imaging in the process. And reinforcement, when you give positive or negative reinforcement equations, the process of data analysis by AI. Therefore, artificial intelligence is divided in several subtypes. Machine learning is the one that we just saw. Deep learning is a specific type of machine learning. We use neural networks, which is neurons. The generative AI is one that gives unique and individualized responses. And the large language model is a type of generative AI that mimics human language. So how can you use pre-hospital care? There are several uses. The pre-hospital recognition with smartphone and tablets given away early neurological signs like face asymmetry, weakness, the variable devices alerting for cardiac arrhythmias, the emergency service dispatch for the warning of the service for that a patient is coming with stroke to start the stroke protocol, the training of the emergency service personnel, also helping novel diagnosis like, for example, imaging, and also localization like see in the following slides. For example, this is a classification in which algorithm learning evaluates the data inputted by someone who puts the data from the patient that is attended by the ambulance in the street or on house to say if the patient is having a stroke, to predict that outcome. And if so, the physician in the emergency department is alerted and the stroke protocol is begun immediately. Also, the classical apps that for image analysis can diagnose early, for example, an LVO or a hemorrhage, especially in those mobile units that has a CT in the ambulance, and the hospital will already know what intervention and which hospital also will be probably the destiny of the patient that needs to make an intervention. This is interesting. There is some research being done, for example, with using geolocalization and Google Maps, for example, based not only on the patient itself, but also on the ways that he can go to the hospital, the emergency service, and the people in the ambulance can direct the patient to the correct hospital based on the needs of intervention, if it's stroke and it's surgery or a thrombectomy and LVO, and which hospital is closer, what is the best way, and also what is the insurance, for example, of the patient that can be done and is being done current research projects. Also, the wearables, as I said, can collect multimodal, very classical health records that we have, and also Fast AI, which is a very simple app that can be having on your cell phone, can detect early facial asymmetry. This is just a picture to illustrate that AI can be done in big data analytics since the financial analysis before the patient even get to pre-hospital care, all the way to the admittance of the patient in the hospital for assistance making by the clinician. Of course, there are some limitations like data privacy, the reliability of internet, the biases that some algorithms can have, especially on which population they study, and also the problem with equitable act. The more you special technology, the more difficult it will be in some place or work to have the technology available to you. So with that, I end the lecture, and for all attention, I'll be open for discussions. Thank you very much.
Thank you very much.
Hello, everyone.
So next we invite Dr. Froch Christian from Germany. His presentation is Pre-Hospital Identification of Intracerebral Hemorrhage by GFAP. All right. Here comes the slides. Yep.
Okay, great. So our group actually worked on the differentiation between acute intracerebral hemorrhage and ischemic stroke with biomarkers for several years. And a clue to solve this problem is actually to consider the different kinetics of tissue destruction in acute intracerebral hemorrhage versus ischemic stroke. So the expanding hematoma immediately destructs astroglial cells, and in contrast, in ischemic stroke, necrotic cell death occurs with much more delay. So on the left side, you can see schematic graphs, which indicates the amount of necrotic cell death in intracerebral hemorrhage much more rapidly in the very first phase due to the expanding hematoma, in contrast to ischemic stroke, where the necrotic cell death occurs with more delay. And this brought us to the point to find a protein which might be released much more rapidly in case of intracerebral hemorrhage in the early phase as compared to ischemic stroke. And we did the same what the cardiologists did with troponin T. We just were focusing on the most abundant protein in our brain, which is actually GFAP. That's an intermediate filament protein located in astrocytes, and it's responsible for the cytoskeleton of the astrocytes. And usually it's not actively secreted, and it's both also highly brain specific. So in our eyes, an ideal candidate biomarker to prove whether this concept which I just mentioned is true. So we did in the previous years several multi-center prospective trials on GFAP. We took blood from acute stroke patients at hospital admission, and then we compared the GFAP levels between ischemic stroke, intracerebral hemorrhage, and stroke mimics. For example, the BFAST-1 trial published in 2012. And I just show you some raw data from this trial to give you a feeling how the data look like. So you can easily identify that in those patients who had intracerebral hemorrhage, the plasma GFAP levels were much higher compared to those patients with ischemic stroke and with stroke mimics. All of those patients were included within a 6-hour time window. And of course, similar to what the cardiologists know with troponin T, also in this case, GFAP correlates highly with intracerebral hemorrhage volume. So that's really a matter of cellular destruction by the size of the hematoma, which finally causes the GFAP evaluation and elevation in the bloodstream. So unfortunately, until now, we were only able to detect GFAP with stationary research platforms. That's what all the previous GFAP studies used. But more recently, since 2022, as Craig Anderson mentioned before in his talk, Abbott brought out a GFAP point of care device, which uses a plasma test. So there is still a centrifugation step necessary. But we get the results after 15 minutes, and it's a handheld device. You can potentially also use it in a paramedic's car. So Abbott released this test with the primary indication to identify patients who have a mild traumatic brain injury, to identify whether they have intracranial lesions or not in order to avoid unnecessary CT scans. And the price per cartridge actually is about $50 US at the moment. So what we then did here at our hospital in the southern part of Germany is that we created a backpack where we put in the GFAP point of care device and a small centrifuge and some equipment to do the pipetting stuff. And then we did several exploratory studies in the upcoming month. And I just show you some examples. On the left side, you see a patient with a typical M1 occlusion within the time window, so an ischemic stroke. And you can nicely see that the GFAP is not elevated, which nicely fits the hypothesis which I just showed you at the beginning. So even if ischemic stroke patients have very large perfusion oxygen deficits, the GFAP levels remain low as long there is no ischemic tissue necrosis. So, but if you measure this patient, let's say after 24 hours, of course, you will find elevated GFAP levels because then you have necrotic cell death and the GFAP levels rise. And on the right side, in comparison, you see a patient with a hyperacute basal ganglia intracranial hemorrhage. And here you can easily see that due to the more rapid tissue destruction, you have an elevated GFAP concentration in the bloodstream. So you can use this test to differentiate in the pre-hospital phase. We did 2 trials. So the one is actually on stroke. It's to differentiate ICH and ischemic stroke. It's not yet published, and the results will be presented at the ISC 2025 in LA. And the second trial was the coma study. So we were focusing on including patients with acute coma who were found somewhere on the road in the pre-hospital phase, because for the paramedics, in case of acute coma, it's so challenging to make the differentiation whether this is due to a severe intracranial bleeding or whether this is a metabolic problem or intoxication or pulmonary embolism and so on. And so the coma patient, the coma study tried to find out whether GFAP could help to identify in an acute coma patient whether the cause of the acute coma is intracranial bleeding. So in this trial, we included patients with a Glasgow coma scale less than 9. Both traumatic and non-traumatic cases were included. And as I just showed you, we measured GFAP on the point of care Abbott Alinity device. We included 143 patients prospectively. Here you can see the baseline characteristics of those coma patients. So on the top you can see the diagnosis share. So on the left side we have intracranial hemorrhage, subarachnoid bleedings, subdural bleedings, epidural bleedings, ischemic stroke, seizures, but also like cardiopulmonary events, metabolic events, and the average Glasgow coma scale in this cohort was about 4. And now you can see the GFAP levels we were detecting from this blood collected in the pre-hospital phase related to the final diagnosis which causes the coma of this patient. And you can easily recognize that brain bleedings or intracranial bleedings cause heavily elevated GFAP levels, in particular in terms of intracerebral hemorrhage and subarachnoid hemorrhage. But those patients who finally ended up with no primary CNS cause of the coma, for example, if they had like cardiopulmonary events or metabolic events or intoxication, they basically had no GFAP elevation in their bloodstream. And finally, we published these results, and within this publication, we also presented the pocket cards for the paramedics, which can be used in the pre-hospital phase. So if you do GFAP point of care testing with this device in the paramedic's car, and if you get a GFAP result, you can use this pocket card in your comatose patient in order to get the probability whether this patient, depending on the GFAP level, has intracranial hemorrhage on. And of course, this might help you primarily to get a perfect triage for this patient. So what we are currently doing for the paramedic system around our hospital is that we do training with the emergency medical services on how to use the device in the paramedic's car. And we also equip some of our rescue helicopters in the area with the GFAP point of care device. So to bring it into practice. And of course, as you all can imagine, not only the improvement of triage might be a strategy which might be improved by this test, but also as Craig mentioned, if you get a positive GFAP result and the likelihood that this patient has intracerebral hemorrhage is so high, then of course, based on the test, and the clinical syndrome and the blood pressure values. A rapid blood pressure lowering in the pre-hospital phase might definitely be imaginable. And based on Craig's very wonderful data, we could have the assumption that even if we don't have very expensive CT scanners in the pre-hospital phase, we might be able in the future, based on this biomarker testing, to bring a highly effective blood pressure monitoring and blood pressure control in the pre-hospital phase in our intracerebral hemorrhage patient into reality. So thank you very much for your attention.
Thank you very much. So we're gonna keep on moving along, and next we're going to invite Dr. Ji Chu Hong from Nantong University. Her presentation is International College Student Network as a task force to improve stroke action awareness. Dr. Ji, you can share your slide.
Okay, thank you. Thank you, Doctor. Thank you very much for this opportunity. Good evening, everyone. My topic is International College Student Network as a task force to improve stroke action awareness. Stroke now is the leading cause of death in China. Improving primary and secondary stroke prevention and cutting down pre-hospital delay has become an urgent mission for both hospital and society. In response to the National Health Commission's call for action on stroke recognition, Nantong University established the Stroke Propaganda Group for college students in 2021 and the Tongyi Health Public Service Center in 2023, which is committed to early stroke recognition education. The team consists of 35 students. They posted Stroke 120 related videos and handed out posters on urban buses and subways. Also, they went to rural areas to share their knowledge about stroke and visited a lot of stroke families to help them. We have established the Stroke 120 Museum as a foundational mission base. There, we hosted millions of people, including students, social workers, and people from all areas. After learning about stroke, many of them became our volunteers, and now they are passing the knowledge on. Our team actively engaged in the public welfare initiatives of the National Health Commission's Medium Disability Reduction, conducting missions in regions including Qinghai, Tibet, Xinjiang, Gansu, and Guizhou. We have invited to visit Field Hospital in Philippines and St. George University in United Kingdom. Our team went to Philippines, and there we have several conferences teaching the public how to recognize stroke with 911, what to do when facing one, as well as some tips to decrease the possibility of having stroke. We also discussed with the local doctors and medical students about how to treat stroke, how to deal with pre-hospital delay, and share helpful experience. At St. George Hospital and the Rural Automobile Club in the UK, we aim to introduce the Stroke 120 to medical students and British functionary, explaining the evaluation and history of the Stroke 120 in China. Currently, our mission service covers 29 cities, 123 communities, and 15 villages. People's Daily, China Youth Daily, and Health News have dominated our efforts. This slide shows the progress after the stroke awareness campaign. We can see that the mission rates within 2.5 hours and 24 hours. Intravenous thrombolysis rate within 2.5 hours and mechanical thrombectomy rate within 6 hours have all increased. On November 17, at the 8th International Conference on Pre-Hospital Medical Care for Stroke, Nantong Station, and the Chinese premiere of our stroke story, our team was awarded the Outstanding Volunteer by CSTS and recruited 300 college students to participate in stroke recognition action. With our work, will advance the International University Student Network as a working group for raising awareness of stroke action. Thanks very much for your attention. Thank you.
All right, thank you very much. We're moving to the next session. We're going to take this opportunity. We have experts from various different country regions with different expertise. I'd like to invite Dr. Mark Fisher, so ex-president of WSO, World Stroke Organization. He's from Harvard University to moderate next session for the discussion. So I guess that the major reason we want to do this academic discussion exchange is to try to improve the stroke pre-hospital care. One of our top question is what are the actions required in pre-hospital care to improve access to acute stroke treatments? This topic was raised by Dr. Gary Ford.
Renu, hi, this is Mark Fisher. I'm here.
Yep.
Can
How are
you
you?
hear me?
Yeah, we can hear you.
Okay. So I joined a little late because it started quite early in my time zone. The presentations that I heard were really quite interesting and informative. So I assume that everybody else had the same opinion. So for this roundtable, we'd like to ask the speakers to participate, and I recognize that the needs for improving pre-hospital care certainly vary based on the country you're in and the region. But if we could get some of the speakers to comment on the question that Dr. Liu just raised, which is what actions in your country and region do you think are most important to improve care? So since this conference is largely being attended by Chinese, why don't we start with some of our Chinese colleagues who might want to address that? So anybody from China want to speak about? So the question is, what do you think is the most important thing in China to do to improve pre-hospital?
I think the critical problem in China of pre-hospital is pre-hospital delay. Because in hospital, the DNT, almost 80% of hospital the DNT is within 1 hour, and the pre-hospital transportation, majority of the area is within 1 hour, and the whole time from the onset to the hospital door in China up to 24 hours nowadays. So I think how to improve from the onset to the patient, people seek for the help is important in China.
So I was actually intrigued by the establishment of the mobile stroke unit network in China. So maybe we could have a comment about what's the financial viability of doing that? Is it cost effective? Who's paying for it? Can we hear anything about that?
Professor Fisher, may I answer a question?
That's great.
In China, we have the different medical system compared to USA or other Western countries, and we know we call the emergency system named 120, and it's supported by the government, almost free for treatment. So we don't think it's a big burden for the patient, and also it's not a big burden for the hospital. And from the list, one professor asked me a question. Let me explain how to do the reverse strategy. I mean that I don't want to use an MSU to replace the ambulance, but just to cooperate with the MSU's ambulance system, especially in the rural area. In China, we have less qualified neurologists or the pre-hospital team. So, especially in my reports, we show a typical region named Suzhou in Anhui province. It's around 500 5 million residents, just around in 100 multiple 80 kilometers. So there we have qualified pre-hospital system, but it's a big burden for the ischemic intravenous treatment, because there are just only one or two qualified stroke center.
We have a lot of others, so can you just come to a conclusion?
Yeah.
Any final comment?
It's almost free for the for the transportation.
All right.
So it's not a big burden.
All right.
Is it free for Beijing or across China?
Not in Beijing, in Anhui province.
So do any other speakers want to comment about the situation and needs for improving pre-hospital care in their country?
Mark, it's Steve Davis. I'd like to make a couple of comments. I think it's been, firstly, an excellent symposium. I've really enjoyed the comments. So I think it's a spectrum of activity. There's not one activity. It's education, reducing delays, improving emergency services. I think mobile stroke units are expanding rapidly in China and in Thailand, interestingly, and also to a lesser extent in Europe and North America. We have 2 units in Melbourne in Australia. I think mobile stroke units are here to stay, but I really think that new imaging devices are going to make them much cheaper and much more readily available. I was interested to see in China their CT scanners under 300 kilogram, which makes it, I think, the lightest currently available scanner. And I think that the GFAP research is really exciting, and I think it immediately opens the prospect of treatment for intracerebral hemorrhage. So I think all of these approaches are going to change things quite rapidly in the next few years.
Anybody else want to? Oh, yeah, Dr. Foucault.
I just want to focus on the pre-hospital delay of the ischemic stroke patient, and actually, including me, some of the doctors presented the pre-hospital delay at the arrival time of the hospital, but their definition of the pre-hospital delay is various. Actually, that's 3 hours or 4 hours or 6 hours or something like that. But when we are doing such research, we may have to get some consensus of the pre-hospital delay. Otherwise, we will compare the different results from the different criteria. So if you are okay, we will have the consensus of the pre-hospital threshold of the pre-hospital delay. In my opinion, the 4 hours is very important, because if you're working very hard in hospital time for the thrombolysis, TPS thrombolysis takes only half an hour. So in my opinion, I recommend the 4 hours. So what do you think? I want to ask everybody here.
Any comments on that?
Gary, what do you think?
Well, I think we certainly need to focus on getting, Steve's point, we've got to get the community awareness. I've been to countries which have, had very good hospital pathways of care, but no awareness, so you don't get the patients coming in with an alert. I think clearly the 4-hour window is the critical one. So I agree with Hitoshi. That early recognition and response. If I had to say what would be the most important thing to invest in that would give us the most gains that would be applicable in most countries, I think it would be the point of care diagnostics. To differentiate hemorrhage from ischemia, because we know from Craig's work that if we can use simple, inexpensive treatments to lower blood pressure very early, we're going to get real benefits from that. So that would be and in countries which have a high prevalence of hemorrhage, like China, that would be a massive step forward. I think what Steve's talk and that really interesting stuff on the development of mobile stroke in China show is, once we can get the imaging in a practical and reliable form, CT or otherwise, then we can really advance even further. I think what's interesting is how far we can go without brain imaging. can we get blood-based diagnostics that give enough confidence to exclude hemorrhage? And that may be within our reach from some of the data we're seeing. But I've been involved in pre-hospital diagnostic studies, and getting a diagnostic that is robust enough to use in the field is quite challenging. But that is a solvable problem. So I think we're on the cusp of having some real advances in the next 5 to 10 years.
Anybody else want to comment?
Yeah. Thank you very much. So I think the most important thing is getting people aware, particularly in Africa, so, and then strengthening the system of care, because it's not just enough to be aware. Like I mentioned, almost 60% of people, when they have a stroke, they go elsewhere, even after recognizing it. And that usually even takes some time before they recognize. So really, we need to work more. And we are trying to do that using social media, using other ways of ensuring that there is early recognition. But that is intricately linked, because you actually need a positive feedback system, so to speak. If stroke is recognized on time, if patients get to the hospital on time, then something must happen also to reward them. And that is, there must be imaging to diagnose as quickly as possible, and the intervention must also be available. So, of course, we are working on some of these with Angels Initiative and World Stroke Organization to ensure that this is important. I mean, these are available. What I think would be a major game changer, and I agree completely with Gary Ford, is a point of care diagnosis, which could be supported by AI tool or remotely by telestroke, so that decisions can be taken and intervention can be given, even if it's blood pressure lowering, which may be useful for hemorrhagic stroke, or thrombolytic therapy for ischemic stroke. So portable MRI, I'm aware, are now available, but they're not yet deployed widely in Africa. For instance, for diagnosing stroke or I mean, for diagnosing stroke and also for distinguishing between ischemic and hemorrhagic. They are low field, about 0.3 Tesla, and they are completely portable, and you can just plug and play, without the need for a lot of energy consumption. So that will really be a huge game changer if that can be deployed in different places, so that once a patient gets there, immediately that diagnosis is made. And GFAP biomarker could also be something that could be a game changer. D-dimer is routinely available, but I don't know how useful it might be in distinguishing in a robust manner ischemic stroke from hemorrhagic. Thank you very much.
Okay. Renu, we're coming up to the top of the hour. We got a late start. Would it be okay to extend this discussion for an extra?
Yeah, we can extend it because I think it's okay to extend it a bit time.
I would like to switch gears a little bit and move from the move to the issue of what would the speakers recommend as the most important area in research to pursue for improving pre-hospital. So a little bit different focus. Craig, we haven't heard anything from you. What's your response to that question?
Yeah, thanks, Mark. Look, before I respond to that, one of the things is that in much of the world, it's fee for service to get an ambulance. And if you are poor, getting to hospital by an ambulance is a great barrier. And so that's why it's cheaper to go on the family bike or something like that. So I think one of the issues is making access a green pathway in the pre-hospital care, cheaper access through ambulance. Obviously, there's got to be ambulances there to use it, but I think awareness and accessibility through ambulance are really important. I do think there's a lot more work to be done on awareness. I think the FAST acronym has worked quite well, but I've been made aware, and it's been alluded to in the speakers here, that doesn't translate very well across different cultures and languages. And I know we always have these national campaigns to raise awareness, but I don't think they're sustainable. I think even in the West, we've plateaued out awareness. I think that there still needs to be a lot more work around awareness of stroke. But The issue is how to do it. So I think research on methods to raise awareness, I think, is really important. And then I think the whole issue of triage, diagnostics and triage and communication, that system of care, pre-hospital system of care. So whether you wanted to look at that as single interventions or look at models of care, I think is avenue for research. But ultimately, if we're going to do this research, we have to bring along government as part of our partners here, because we want to have the research translatable very quickly. So I think the various stakeholders here between government, university, and hospitals and ambulance to make our research rapidly translatable is really important.
Thank you. Great summary. Anybody else want to add their opinions here about where the research should be going over the next 5 to 10 years?
Yeah, I think one of the main things that could actually be a game changer is just like the portable MRI, if that can really be made in such a way that it is affordable, it is cheap and is available, something that is not big, a point of care diagnostic really, I think would be really transformative. And I think we are probably not yet there. Well, you don't really need a bogus equipment to be able to take pictures of the brain and say, this is hemorrhagic stroke, this is ischemic. So the earlier we're able to get there, I think the better. That will really be transformative, at least in terms of deciding whether this is a stroke, this is ischemic, this is hemorrhagic. And then, of course, telecare can help in taking decisions and deploying the right intervention for the right patient. But using social media to raise awareness, using home video, those are all very, very important so that people can recognize stroke as soon as it occurs. Of course, we will do even more good by trying to prevent stroke. But whenever it occurs, within the next few minutes, whoever is there, if the patient is not capable any longer, should be able to recognize, and then there should be an alert system which would then immediately provide an intervention that could potentially reverse. Thank you.
Liv, can I make a very short comment, Dr.
Sure.
Sunil? Hello? Yeah.
We can hear you.
So one thing which I think will be more practical when government get involved and when the national agencies get involved is to get it along with all the acute care of other NCD as well. Like we must have a kind of a common program to reach acute stroke, MI, maybe acute respiratory failure or renal failure. All these together, reaching them, these kind of cares more close to the patient and then bringing them to the hospital instead of trying it for stroke alone. Maybe more pragmatic and maybe more helpful to get the government and national aid support. So this
excellent point.
Probably already there we are doing this, like the chance of getting WHO, WS, all the support. It's difficult to get everything coordinated, but I think whatever we can do in this direct help.
Any other comments? I know it's getting late. Some of you. Craig, are you in Australia? You guys are you in Australia right now?
Yeah.
So it's the middle of the night.
Yeah. We should Steve and I should get awards.
Yes.
Yes.
Profiles encouraged. Any last comments? Because I know it's late for the people in China as well. Renyu,
Dr. Fisher?
Yep.
Yeah, this is Amit Kandel. Just a quick one. Door to needle time does not do recognition and justice to pre-hospital. So as a task force, if we can move to onset of needle time, then that will account for all the good work done in the pre-hospital setting. And not the research, but one part that I would say for next 5 years, if we can improve the education of neurology, whether it's a medical student, residency, developed country have neurologists 1 in 100, but the developing country have 1 in million. So the education is the area where we need to focus for better pre-hospital care, because that will translate to public awareness as well as EMS system. Thank you.
Okay. Gary and then Renyu, do you guys have any closing comment?
Well, I was just going to specifically pick up Craig's point, then make some general comments and thanks. So I think Craig's 2 points I think were really important. The one about how do we have a sustainable system of maintaining public and community awareness. And I think we should think hard about that. And that means working with government and behavioral science. And the second is, I think, that other point about how do we get the policymakers and government more on a line to invest in the pre-hospital response, because we've seen in many countries that we haven't got that investment, which would actually be hugely resource saving, for example, if ambulances were freely available for acute stroke. And I'm always conscious that there are very few really time critical acute emergencies in medicine. And stroke is generally not a big an ambulance response priority as it should be. I mean, stroke is more time critical than most major trauma. When we look at what comes in as major trauma, you've got acute coronary syndrome, cardiac arrest, and then probably sepsis, but there's really nothing else that is as critical. So I think thinking more broadly, and that's where WSO I think can be really helpful as we engage with it in terms of supporting that internationally. And Mark, I just wanted to say I've really enjoyed the talks. I think it's been really excellent, and really want to thank all the speakers for the excellent contributions we've had and managing to pack so much in this short 3-hour meeting. Thank you.
Anybody else have any closing comments?
So do we have a common minimal program on a global level to improve the pre-care, sort of basic minimum goals or current state? It's a real problem. This is where a lot of patients are dying. Generally, all academicians, neurologists, they all very often are more focused providing acute care. Only the private hospitals compete each other to get the patients from periphery to them as early as possible because of the themselves. But among academia and science, is more of a social science. We need probably a more compassionate so that's sometimes from the focus academic.
Okay, maybe I think that pretty late, especially for Dr. David, Stephen, and Craig. In a couple of few years, we tried to different model for the specific discussion for stroke pre-hospital care. We did a combination of on-site and online. The year before last year in Philadelphia. And then last year we did the on-site meeting in Toronto, and then coming up with extended online session. So this year we tried a little bit slightly different, but similar to we did last year. We did 2 on-site meeting, one in Shanghai. Actually, Mark Fisher went with me there, and one in Nantong, and to help the local area to kick off the programs in the local area and help them to improve stroke awareness. Then we have this dedicated online session. So I think this is a good model in a combination of on-site local meeting, focus local area, and then you have a group meeting online, bring the experts from different countries, regions. We're trying to find the best time that everybody can in the same room to discuss. We're looking for next year if somebody who willing to host locally, we can support your activity there, and then we have similar online sessions. As you see that Dr. Pandian, the current WSO president, laid out his the WSO action plan for pre-hospital care. We want to work together to come out a really practical plan, especially for low resource settings. I think Professor Anthony Rudd is writing review articles on that. I think that today, because of time very limited, because of the time zone difference, all sort of things. Please send us your thoughts by email to me and to our group. We can put it together. I think in the future we could potentially organize more smaller group meetings for specific topics, and then come out the real plan what we should do and have some actual action plan moving forward. I really appreciate everybody to join us, especially these who are in a deep late night or in the very early morning, and to join our 8th international meeting dedicated to the stroke pre-hospital care. We're making some progress, but we're hoping that it will make a more huge steps forward.
So I have a few closing thoughts. I joined a little bit late, as I said, but I found the talks to be quite interesting and educational. It looks to me that improving pre-hospital access and care is really the next great frontier for acute stroke management and treatment. So the WSO task force has a lot of work to do, and I see two main areas of focus. One is educating the public so they actually recognize stroke symptoms in a timely manner and then hopefully act on it because they either know what to do or they can access people to help get them to. And the second area of focus that I see is improving the pre-hospital diagnosis. So I was particularly intrigued by Dr. Forsh's presentation on GF. So that could be a big step forward in helping to distinguish between ischemic and hemorrhage. There are others, obviously, the pre-hospital imaging, as that becomes more readily available. But those, I think, are the two big areas that I take away from this presentation and the discussion. So the task force has a lot of work to do, and we also support it. So I thank everybody for their participation and attention. And does anybody else have any just last brief comments?
It seems
If not,
Greg wanted to say something.
we should congratulate Renyu and Jian for organizing this great conference today. And thank all the participants being part of it.
Thank
We'll
you.
see you all soon, hopefully in LA in a couple months. Take care.
Thank you.
All right.
Bye-bye.
Thank you.
Bye.
Thank you, everybody.
Bye. Thank you, Erin.
Bye.